So today's class was concerned with puberty, and what we'll be going to study is basically these different subtopics under which the class will continue. So what is puberty? Puberty is the period of transition during childhood to adulthood, during which female achieve their sexual maturity and become capable of reproduction through several biological, physical, and psychological changes. Age of puberty is variable and depends upon genetic, environmental, nutritional, and racial factors. The normal age of puberty in girls lies between 8 to 13 years, although sequence, timing, rate may vary. What hormones change in puberty? There is increase in glutamate, neurokinin, leptin, and kiseptin, and there is decrease in GABA and neuropeptide. What happens basically in the hypothalamo-pituitary ovarian axis as puberty is activation of arcuate nucleus in hypothalamus results in pulsatile release of gonadotropin releasing hormone, and this further releases the gonadotropins, luteinizing hormone, and follicular stimulating hormone. These act on ovary, and there occurs release of estrogen and progesterone, and mainly estrogen is responsible for the formation of the secondary sexual characters. So this is the basically HPO axis, the activation of HPO axis that results in the change in the pubertal, that results in puberty of the female. What are the different signs of puberty in girls? Hair growth, mood swings, breast budding, height spurt, periods, pimples, or acne. And puberty, the sequence basically is there occurs growth spurt followed by breast budding, that is thelarchy, pubic and axillary growth hair growth, that is adrenarchy, then occurs the peak growth in height and followed by menstruation. Stages of puberty in female, first one by one we'll see it. Physical growth and body weight. The height and weight growth in girls starts at 9 to 11 years, mean age being 10.5 years at the rate of 8.3 centimeter per year. The growth spurt occurs due to activation of growth hormone, estrogen, and insulin growth factor 1. Body shape becomes feminine with widening of the pelvis, bone mass, enlargement of facial bone, and vital capacity of lungs also gets doubled. And breast development, that is thelarchy. It occurs through different stages, and these stages are described by Tanner as from 1 to 5. In first stage, there occurs elevation of the papilla only, that is the pre-adolescent stage. Then occurs a small mount. Sometimes the the kid might complain of pain at the nipple side. This is the point where occurs elevation of the papilla. Then second occurs a small mount is formed by the elevation of breast and papilla, and areolar diameter enlarges. Then at this Tanner stage 3, further development of the enlargement of the breast occurs and areola occurs. Then there occurs projection of the areola and papilla to form a secondary mound above the level of the breast. In these pictures, you can see there in the first picture on lateral view, you can see there is elevation of the papilla only. Then on the second picture, there is formation of areola. Then the further enlargement of the breast is occurring. Then after the enlargement of the breast, there occurs projection of the areola and the papillae. And then a proper matured breast is formed in the stage 5, where areola is recessed to the general contour of the breast. Similarly, there occurs pubic and axillary hair development, that is pubarchy. In stage 1, there is no pubic hair. In stage 2, there are small amount of pubic hair along the vaginal lips. Then in stage 3, hair are darker, coarser, and curlier, and spreads coarsely over the skin around the vaginal lips. Then in stage 4, hair is now adult in type, but the area covered is smaller than in most of the adults, and there is no pubic hair on the inside of the thighs. In stage 5, hair in adults in the type distribution and inverse, like an invert triangle, and there may be hair on the inside of the thighs as well. So these are the different stages of the pubic hair growth in females. Then occurs the menstruation, that is menarche, that is the onset of the menstrual cycle occurs about 2 to 2.5 years after thelarchy, and the median age of menarche is 12 years. Anovulatory cycles are common in the first 1 to 2 years after menarche. After that, development of the ovaries and genital organs occur. The ovaries increase in volume and Graafian follicles start to develop. Uterus increases in length about twofold and volume about tenfold. The uterine cervix ratio becomes 2:1 to 3:1 at puberty. As we know that at the birth, the ratio is just reversed. That is, the cervix is around 3 times more than that of the uterus, but at puberty, there occurs more growth of the uterus than the cervix. The vaginal epithelium becomes stratified, multi-layered under the effect of estrogen. Vaginal pH decreases to 4 to 5 due to lactic acid production by lactobacilli, that is the Dodelins bacilli, and there is deposition of fat in the labia majora. Then the psychosexual maturity occurs and girls at puberty become shy, introvert and moody with improvement of intelligence and cognition. Sex urge begins and they become interested in opposite sex. Skin changes occurs and these are shown in the form of acne and comedone. Then what are the different abnormalities at puberty? It could be delayed puberty or precocious puberty, that is early puberty. There could be menstrual problems like that of amenorrhea, dysmenorrhea, puberty menorrhagia, or cryptomenorrhea. Miscellaneous conditions like PCOS, hirsutism, infections, tumors, endometriosis, and adenomyosis. These are the different problems that are present in pubertal age group. Delayed puberty, if the secondary sexual characters or the breast development, that is the breast development and pubic hair do not develop by age of 13 or menarche is not attained by age of 15, then it is known as delayed puberty. What are the signs of delayed puberty? There are no breast buds by the age of 13 years. There is no growth of the pubic hair. There is no menstrual flow by 16 years of age. There is underdeveloped uterus and a slower rate of growth is there. That is the stunted growth. Cause, what could be? Ovarian insufficiency, hereditary, underweight, nutritional deficiencies, eating disorders, and hormonal imbalance could be the cause for delayed puberty in girls. What is the etiology for the delayed puberty? It could be constitutional delay, which is the most common one. It may be because of anatomical causes, or it may be because of hypogonadotropic hypogonadism or hypergonadotropic hypogonadism. So, and other one is psychosexual, chronic disease, polycystic ovarian disease, and AIS. So anatomical changes, that is anatomical cause, that is eugonadism. It may be because of Mullerian agenesis, that is there could be dysgenesis of the Mullerian duct, or it could be cryptomenorrhea, that is imperforate hymen, or it could be transverse vaginal septum. Hypogonadotropic hypogonadism, that is the defect lies at the level of pituitary and hypothalamus, and there occurs isolated growth hormone deficiency, there occurs short stature. Kallmann syndrome could be there, where there is isolated deficiency of GnRH, or CNS tumors, infection, trauma could be the cause. Hyperprolactinemia and hypothyroidism also are the causes for delayed puberty. Hypergonadotropic hypogonadism, which is where the defect lies at the level of the gonads, that is the gonads are not working. In this case, there could be streak gonads like in Turner syndrome, premature ovarian failure, pure gonadal dysgenesis, or resistant ovarian syndrome. Psychosocial, where there are eating disorders, excessive exercise, or stress. These may also result into altered pubertal changes. Diagnosis depend upon detailed history taking and physical examination, and physical examination involves height, weight, BMI, secondary sexual characteristics. Investigations, lab investigations that are included are the hormonal assay, that is the FSH, LH, prolactin, thyroid hormone, and testosterone. USG or MRI abdomen, CT or MRI head for pituitary tumors, and karyotyping for hypergonadotropic hypogonadism. Management in constitutional delay, reassurance is basically required. Hypogonadism, in hypogonadism, estrogen therapy followed by estrogen and progesterone therapy is required. Now, precocious puberty, what it is defined as the onset of secondary sexual characters before 8 years of age or onset of menstruation before the age of 10 is known as precocious puberty. What are the signs of early puberty? There is breast development, pubic hair growth, increase in height, hips become broader and her waist become thinner, sweaty and adult-like body odor, acne, vaginal discharge, or early menarche, that is onset of menstruation. What are the causes of early puberty? Environmental factors such as exposure to certain chemicals or pollutants, poor diet and nutrition, vitamin D deficiency, chronic stress, genetic and hereditary factors, hypothyroidism or underactive thyroid gland, being overweight, which creates high estrogen level in the body and problems with the endocrine gland. What are the types of precocious puberty? True precocious puberty or the central precocious puberty or GnRH dependent precocious puberty, pseudo precocious puberty or peripheral or GnRH dependent independent precocious puberty. True precocious puberty, due to early activation of the hypothalamo-pituitary ovarian axis, there is early development of secondary sexual characters with gametogenesis, cause being idiopathic or genetic commonly in more than 75% of cases, or it could be because of CNS tumors, that is the pineal body tumor, or CNS infections like post-meningitis, encephalitis, TB, head trauma. Complete precocious puberty where the sexual characters and menarche both have developed. Incomplete precocious puberty where one or two secondary sexual characters develop but there is no menarche. Pseudo precocious puberty, here there is an elevated estrogen with low gonadotropin releasing hormone. This early development of secondary sexual characters without the gametogenesis, that is no ovarian development. Secondary sexual characteristics could be either isosexual or it could be contralateral. Etiology being ovarian causes like estrogen or testosterone producing tumors, granulosa cell tumor, androblastoma, McCune-Albright syndrome, adrenal causes or tumors like congenital adrenal hyperplasia, then hepatic causes like hepatoblastoma, androgenic causes like exogenous androgen or estrogen exposure, and primary hypothyroidism. So what are the investigations that we should go for? Detailed medical and surgical history has to be taken. Hormonal assay like FSH, LH, HCG, TFT and DHEA has to be done. USU, abdomen and pelvis along with CT for adrenal and ovarian tumors, CT and MRI of the skull for intracranial pathology, and radiography for hand and wrist for the bone age. Treatment, GnRH agonists are the treatment of choice for GnRH dependent precocious puberty. Here we give leuprolide 3.75 milligram monthly subcutaneously or IM. Triptorelin 11.25 milligram every 3 months for 1 year. Gocirelin 3.6 milligram monthly. DMPA injection also is a good alternative and it can be given at 100 to 200 milligram IM. It inhibits menstruation and bone growth, but it has no effect on the skeletal growth. Menstruation problems that occur during puberty are the puberty menorrhagia, cryptomenorrhea, dysmenorrhea, amenorrhea. Puberty menorrhagia is a type of anovulatory bleeding that occurs due to estrogenic stimulation of endometrium, causing persistent proliferation and hyperplasia, followed by breakthrough of the proliferated endometrium due to absence of progesterone support, causing painless, irregular, and prolonged menstruation. Absence of progesterone is responsible for decreased secretion of thromboxane, prostaglandin F2, and increased secretion of prostacyclin and prostaglandin E2, which causes vasodilatation leading to heavy menstrual bleeding. This may be because of immaturity of the HPO axis, which occurs in the early 1 to 2 years of post-menarche, or it could be because of coagulation disorder or von Willebrand factor defect, or hypothyroidism, liver disease, granulosa cell tumors of the ovary. Investigation that we need to go for is the complete blood count, thyroid profile, liver function test, coagulation profile, USG abdomen and pelvis, and management includes, after ruling out different causes, tranexamic acid, norethistron 5 milligram thrice daily or oral contraceptive pills and hematinics for anemia. What are the differential diagnoses for puberty menorrhagia? There could be foreign body in the genital tract, or it could be because of sexual abuse, which resulting in trauma, or trauma to the genital tract. Neoplastic cause like sarcoma botrytis, or miscellaneous cause like leech bite, bleeding from rectum can also be there. Then dysmenorrhea. Dysmenorrhea is defined as painful menstruation of sufficient severity so as to affect day-to-day activity. It is due to increased prostaglandin causing dysrhythmia and increased uterine contraction by vasoconstriction. In puberty cycles are mainly painless, and painful cycles indicate that there is ovulation happening. It could be primary dysmenorrhea or secondary dysmenorrhea. Primary dysmenorrhea where there is no pelvic pathology. Secondary dysmenorrhea is usually associated with pelvic pathology. Treatment for primary dysmenorrhea is in NSAIDs or oral contraceptive pills. In secondary dysmenorrhea, the treatment of the pathology has to be done. Then cryptomenorrhea or the imperforate hymen, where the menstrual blood is collected behind the hymen, causing hematoculpus, hematometra, and hematosalpinx. Presents with primary amenorrhea. Here there is cyclical abdominal pain with urinary retention and palpable abdominal mass. Local examination reveals presence of bluish membrane at the introitus, and treatment is cruciate-shaped incision has to be given over the membrane over the introitus. This is the photo that is showing absence of vagina, and there is a membrane that is closing the vagina. The arrow are showing different structures. Then other miscellaneous problems in puberty are the hirsutism, pelvic inflammatory disease, leukorrhea, and vulvovaginitis. Leukorrhea is defined as excessive white discharge per vaginum due to excessive mucus production by cervical gland under the effect of estrogen. It is usually non-pruritic, non-foul smelling, and if foul smelling and pruritic, then underlying infection is there. Management is basically self-limiting and requires only reassurance, vitamins, and proper nutrition. Vulvovaginitis. It is due to poor perineal hygiene. Organisms mostly involve E. coli, Streptococcus faecalis, beta hemolytic streptococci, candidiasis, etc. What we need to do is advise perineal hygiene, sitz bath, and antibiotic according to the organism that is associated with the vulvovaginitis. Then another disorder that is found during puberty is the eating disorder, that is the anorexia nervosa, bulimia nervosa, or binge eating disorder. Anorexia nervosa is presence of restrictive behavior towards food intake. It could be restrictive or it could be binge and then followed by purge. Patient is afraid of gaining weight and there is decreased BMI. They have distortion of body image, amenorrhea, bradycardia, hypotension, hypothermia, or salivary gland enlargement. They have decreased estrogen, follicular stimulating hormone, or luteinizing hormone. Treatment is basically psychotherapy, sufficient calories in the form of divided meal with fluid and electrolyte, and caution has to be taken to prevent refeeding syndrome. What could be the health causes of anorexia? It may result into fainting, fatigue, bad memory, the loss of hair, dry hair, or thinning of hair. It may be associated with low heart rate, low blood pressure, risk of heart failure. Severe dehydration may result into kidney failure. It results into constipation, bloating, muscle pain, and all over the body. Skin may become yellow and dry, and there could be osteoporosis of bone. Bulimia nervosa or binge eating followed by purge is a pattern, that is excessive eating followed by self-induced vomiting. Use of laxatives to prevent weight gain. Diagnosis is by symptoms twice weekly, or it occurs twice weekly or 3 months for 3 months, and weight is normal. There may be oral trauma and Mallory-Weiss syndrome due to repeated forceful vomiting. There may be menstrual symptoms like oligomenorrhea or amenorrhea. Treatment is basically complete blood test and has to be done, and antidepressants like fluoxetine may be added. What are the different signs and symptoms? Being overtly sensitive as regard to body image and weight, rushing to the washroom immediately after meals, self-medicated laxative diuretics and enema eating after eating, forceful vomiting or purging after binge eating, using dietary supplements and herbal products for losing weight, strict fasting, restricting diet, or avoiding certain foods between the cravings, drinks excessive amount of water or non-caloric beverages, stealing or hoarding food in storage places, fear of eating in public places with others, and a consistent fear of weight gain is there. These are the different signs for bulimia. Then comes the binge eating disorder. Here there is excessive eating without any compensatory behavior. There is increase in BMI. The treatment involves is the selective serotonin reuptake inhibitors. Binge eating disorder signs are eating until uncomfortably full, eating to ease stress and anxiety, recording weight fluctuation, consuming excessive amount of food in short periods, feeling desperate to control eating and lose weight, self-disgust, guilt, or depression after binge eating. Nutrition. Good and balanced diet is needed, and junk food should be avoided. Sexual education, counseling, and contraceptive during the pubertal age. Due to change in society, media influence, altered moral and ethical values, young women indulge in sexual activity, and almost 10% pregnancy and about 8% MTP occur in this age group. There is a need for sexual education and contraceptive awareness in adolescents to prevent unwanted pregnancy and reproductive tract infection. They should be encouraged to avoid multiple partners, and barrier method is best as it prevents both pregnancy and sexually transmitted diseases. Emergency contraception should be altered for unprotected coitus or contraceptive failure. Then safe MTP procedures should be offered. Vaccination. Vaccination during puberty involves the tetanus vaccine, hepatitis B vaccine, and this HPV vaccine. Age group is usually for HPV vaccine, age group is usually 9 to 26 years. Ideal is 11 to 12 years. Extended age group is around 27 to 45 years. Doses more than 15 years, we give 3 doses at 0, 2, and 6 months. At less than 15 years, 2 doses, that is 0 and 6 months. Ideally, these vaccines should be taken prior to sexual activity when its beneficial will be greatest. But history of prior sexual activity, HPV-related disease or HPV test are not contraindication to vaccination. HPV testing prior to HPV vaccine is not recommended. And according to WHO recommendation of April 2022, between 9 to 14 years, 1 or 2 doses has to be given. Between 15 to 20 years, 1 or 2 doses. At more than 21 years, more than or equal to 21 years, 2 doses at 6-month interval. And in case of HIV positive person, the doses has to be given 3. What are the different vaccines that have been approved? Cervarix, Gardasil, and Gardasil 9. Cervarix is a bivalent vaccine. It contains 16 and 18 HPV strains, and it can be given to females of 9 to 25 years. Then Gardasil contains this 4 strains, that is the 6, 11, 16, and 18. It can be given in male and female both between 9 to 26 years. And Gardasil 9 can also be given in males and females both between 9 and 26 years. And it contains 9 strains, that is the 6, 11, 16, 18. Other than that, 31, 33, 45, 52, and 58. Other than this, Indian vaccine, that is the Cervavac, is also in market. That is a quadrivalent vaccine and active against 4 strains, 6, 11, 16, and 18. And it can be given for males and females and in the age group 9 to 26 years. Somebody has written, what is the cause of hematocolpos before menarche? Basically, before menarche, usually hematocolpos does not occur until and unless there is some kind of bleeding inside, then only hematocolpos will be there. And if there is no, either it could be because of injury or something, but then there has to be anatomically closed this tract, then only hematocolpos will occur. If there is no membrane, there is no transverse septum, then there is no question of occurring of hematoculpus. And this is what that is concerned with pubertal age group. I think this is a short topic and there is nothing else to add up in this. If anybody wants to ask any kind of question. Yeah, Dr. Umesh Shah has asked this, na, what is the reason for hematocolpus before menarche? This is the question of you.
Dr. Umesh Shah asked only this question.
Yeah, basically, if there is no tract obstruction, then there is no question of hematocolpus. And before menarche, when the uterus is not bleeding, usually there is no hematocolpus that occurs. If he can ask in, he's writing in, can he ask on his own? I mean, I want to hear his voice.
Dr. Umesh?
I just want to know what is the causes of hematocolpus before menarche, before bleeding. Menstruation occurs.
There is no, there doesn't occur hematocolpus before bleeding. I mean, if the female is having regular cycles, then only hematocolpus will occur with an outlet tract obstruction.
In ultrasound, I have seen one patient, and she was saying that I don't have bleeding yet, but during while doing ultrasound, I saw fluid collection in her uterine cavity. So I think
Uterine
that might
cavity
be
and outlet with the vagina was intact.
vagina. How can I see in ultrasound? That is not
That is
possible. I
what
am
I'm
asked
saying.
that.
That is what I'm saying. If the patient has attained menarche, then only hematocolpus will occur, because if there is outlet tract obstruction along with this menarche, then only the hematocolpus occur. What was the age of your patient?
14 years.
15 years. It means she must be having this cryptomenorrhea. The vagina must not be intact. There must be some obstruction. That is why she was having hematocolpus.
Okay, thank you, ma'am.
Okay. Thank you then.
Okay, thank you, ma'am.
We're closing the topic.
Okay.
Thank you, everyone.